immune therapies for AML has been a difficult nut to crack. There's reasons for that. First, that the targets expressed on AML are also expressed on hematopoietic stem cells. So an effective targeting strategy would also result in prolonged pancytopenia because of the co-expression of the same antigen on AML cells and on a normal hematopoietic stem cell. And you need hematopoietic stem cells to survive, since you have to recover your blood counts. So that's a key issue. The second issue is that these targets are also expressed on myeloid cells, specifically granulocytes and monocytes. And the technical term is a co-expression of myeloid targets. And this results in the direct targeting of these myeloid cells with activated T cells, which results in the not only killing of these cells, but in the release of cytokines, specifically cytokines and chemokines that are the sum and substance of cytokine release syndrome and neurotoxicity. So one would expect that if you're directly targeting myeloid cells, you're also going to get exaggerated cytokine release and all of the symptoms related to that, including some level of neurotoxicity. And the second issue is that since the target is expressed on myeloid cells, there's a huge number of myeloid cells. Even if a patient is pancytopenic and these myeloid cells are present in the organs, such as the liver and the Kupffer cells, or the lung and the pneumocytes, or in the tissues, Langerhans cells. So these myeloid cells express the target antigens, and they serve as a large sink so that the potential efficacy of any immunotherapy is going to be diminished. And this is exactly what's been seen when groups have targeted AML using immunotherapy with either bispecific therapies or CAR T. And that is that the two things that seem to happen in every patient is that there's excessive cytokine release and there's very limited clinical benefit. And so I think the issue of cytokine release is now well defined and well described and makes some biologic sense. And that is that activated T cells directly targeting a myeloid cell, which has the capability of making all of these cytokines and chemokines, is the cause of the cytokine release syndrome. But the issue of lack of efficacy remains somewhat of a problem. Why should necessarily this be the problem? And so when one targets these AML cells in an immunodeficient mouse, one sees that he's either using CAR T or bispecifics, that the AML cells can be effectively cleared. However, in an immunocompetent mouse model, or in a mouse model that has human myeloid cells, the clearance of these tumors is much more difficult, suggesting that there may be something else going on. That is, that the myeloid cells themselves could be immunosuppressive, or simply that they serve as an enormous sink of target, so that you have to get by those myeloid cells to get to the real AML cells. The third possible explanation is that the myeloid cells themselves, believe it or not, may actually perform in a positive way. That is, they may enhance CAR T or bispecific therapy killing of AML cells. And that when you eliminate them, that positive effect is dissipated and the effect of the immunotherapy is reduced. So the reality is that targeting AML using immunotherapy has been challenging, and this has resulted in very limited progress. Even though the antigens are expressed at levels, the side effects such as cytokine release syndrome, fevers, chills, hypotension, edema, shortness of breath, all of these things, and even neurotoxicity can be significant. But more importantly, there's a curious and annoying reduced response of AML cells to CAR T or bispecifics, where one would expect better effects with the targeting agents in the clinic at this point. So the way around this is to find a way to engage the myeloid cells of the host without directly targeting them. That's going to be difficult. And second is to find specific targets that are expressed in the AML cells, not in the normal myeloid compartment. That may or may not be possible. Significant efforts by many groups, including our own, taking proteomic approaches and genomic approaches, has not been successful in defining clearly dramatically differentially expressed genes and proteins in AML versus normal hematopoietic stem cells or normal myeloid cells, such as monocytes or granulocytes. Without that smoking gun, I think that the thought of targeting a unique antigen on an AML cell that's not a normal stem cell or a myeloid cell be fantasy going forward, and more creative approaches will need to be considered before effective therapy for AML can occur.